intellectual disability, autism spectrum disorders, cerebral palsy, visual and hearing impairment. The current preferred term for infantile spasm is an epileptic spasm or a West syndrome. West syndrome is now understood to be an age-dependent epileptic encephalopathy, an expression of brain injury to any cause, which may be prenatal, perinatal, or a postnatal insult. The pathophysiological mechanisms are not well understood. One of the most recognized epileptic encephalopathy in infancy, it is infantile spasm or the West syndrome. And the West syndrome characterized by triad of salam attack, psychomotor development delay, and hips arrhythmia on EEG. Which are the clinical expressions of infantile spasm? Mostly seen in boys 40% and the peak age of onset between 4 to 6 months. And about 90% of the cases present in first year, but may occur anytime in first 2 years of life. 90% of infantile spasm begins before 12 months of age, late onset after 2 years of age. Epileptic spasm may occur and may be intermixed with tonic, partial, and myoclonic seizures. The spasm may be flexor, it is 50 to 60%, with sudden flexion of the neck and the arm and the leg. Extensor spasm, it is about 20%, with sudden extensions of the neck, arm, and the leg, like hugging posture, or mix about 40%, with the flexion of head and arm and extensions of leg, or vice versa, of a flexor spasm in some clusters and extensor spasms in others. The spasms are in general symmetrical on both sides, but at the time may be asymmetrical. Typically, the infantile spasm occur in clusters and generally on awakening, and clusters may vary few to several times a day, and each clusters consist of 3 to 4 to the several spasm in a day. They rarely occur during sleep. Crying and irritability and other behavioral changes are often seen during or after the clusters. Child may be less responsive after the spasm, and eye deviation and nystagmus may occur. Some spasm may be precipitated by sound, touch, and rarely by photic stimulation. And most of the children have an underlying neurodevelopmental impairment secondary to the various etiology. And the small number of the cases may be apparently normal, but may show regression after the onset of the spasm. EEG shows hips arrhythmia, which consists of chaotic high voltage slow waves and multifocal spikes and sharp wave. It may decrease or disappear during rapid eye movement, that is a REM sleep. Modifications and variations of hips arrhythmia may occur. These include presence of focal abnormalities, burst suppression, slow waves without spike, and sometimes asymmetrical. Hips arrhythmia may not seen in all cases. In some cases, it may not present at onset but may appear later. Infants with focal EEG abnormality are likely to have associated focal seizures. Etiology of infantile spasm or the West syndrome. Infantile spasm may be symptomatic cryptogenic or idiopathic, possibly genetic. Most over 80% are asymptomatic and wide variety of underlying disorders associated with infantile spasm. Some of these, as seen in our set, are cerebral palsy 30%, neurocutaneous syndrome 15%, and other are CNS malformations and CNS infection present in infantile spasm. Neuroimaging reveal in case of West syndrome, that is cerebral atrophy, periventricular leukomalacia, cerebral dysgenesis, tumors, and other abnormalities on imaging of a child with infantile spasm. Which are the common etiology of infantile spasm? Prenatal. In case of cerebral dysgenesis, there is a polymicrogyria, schizencephaly, focal cortical dysplasia, and other neuronal migration disorders and microcephaly. In neurocutaneous syndrome, there is a tuberous sclerosis, Sturge-Weber syndrome, incontinentia pigmenti, and congenital infection, there's a torch infection, Down syndrome, and the trauma. It is common etiology for infantile spasm or a West syndrome. So which are the perinatal etiology? In case of hypoxic ischemic encephalopathy, CNS infection, meningitis, and encephalitis, intracranial hemorrhage, trauma, and in postnatal etiology, there is a CNS infection in meningitis, encephalitis. In neurometabolic, there is a phenylketonuria, non-ketotic hyperglycemia, maple syrup urine disease, and mitochondrial disorders. And sometimes there is a degenerative disorders of the brain. So which are the pathogenesis of this West syndrome or a infantile spasm? Various proposed mechanisms include dysfunction of monoaminergic neurotransmitter system and derangement of neuronal structures in the brain stem and abnormality of immune system. Also, overproduction of corticotrophin releasing hormone, CRH, secondary to the CNS insult during critical period of neurodevelopment may result in neuronal hyperexcitability and seizures. Adrenocortical ACTH hormone and glucocorticoids, it suppress the metabolism and secretion of CRH. There is a corticotropin releasing hormone by a feedback mechanism, and it may explain their efficacy to in control infantile spasm. The number of CRH receptors decrease with the age, and this may explain the nature of history of resolution of infantile spasm even without therapy. Differential diagnosis of infantile spasm or the West syndrome. It should be differentiated from mild or incomplete spasm, need to be distinguished from benign myoclonic epilepsy of infancy, there is BMEI. Early myoclonic encephalopathy, there is a EME. And early infantile epileptic encephalopathy. How to evaluate the case of West syndrome? All children with infantile spasm or a West syndrome must have detailed history and thorough neurodevelopmental assessment. Particularly, the skin must be looked at closely for ash of leaf to rule out tuberous sclerosis. Neuroimaging. Neuroimaging is indicated in all cases depending on the suspected etiology, and MRI for cerebral dysgenesis and CAT scan for calcified tumors and intrauterine torch infection. Abnormalities are seen in almost 80% case of West syndrome. If neuroimaging is normal, further metabolic workup is needed for diagnosis of etiology of West syndrome. Pyridoxine 100 milligram intravenous with EG monitoring should be tried in a cases where no etiology identified. In responsive cases, the EG improved soon after the injection. These children would be needed to continued oral pyridoxine 50 to 100 milligram per day.